It's clear that defeating Alzheimer's will take a concentrated effort at many levels. While scientists and researchers work to develop a treatment, how are health officials, patient advocates, and physicians collaborating? For more on this front, please welcome on stage Robert Egge, Chief Public Policy Officer and Executive Vice President of Government Affairs at the Alzheimer's Association, Dr. Sherry Ling, Deputy Chief Medical Officer with the Centers for Medicare and Medicaid Services, Dr. Scott Turner, Director of the Memory Disorders Program at Georgetown University Medical Center, and Dr. Julie Wood, Senior Vice President with the American Academy of Family Physicians. This morning's panel will be moderated by the Hill's health reporter, Peter Sullivan. Peter, over to you.
Thank you, and thanks again for everyone joining us. So we've heard from some lawmakers and some other great speakers, so we want to now have a panel and kind of just dive in a little more. So we've obviously been hearing about this, but maybe Robert, I'd start with you and just kind of talk a little, get us kind of a baseline of just kind of the scope of the problem and kind of how it's growing. Are we, with the aging, we're expecting more people to have this, more of a budget impact. I mean, what's kind of our situation here?
Thanks, and thanks to everyone who made this morning possible for this great discussion. We've heard some of the facts layered in and some of the stories that are underneath those facts. I thought the speakers already have done a wonderful job of laying things out. And there's a lot of facts and figures behind where we are today. I won't do too many of those, but as we've heard, over 5 million Americans with Alzheimer's-related dementias already. That number's set to grow very quickly in the years ahead if something doesn't change that trajectory. Caregivers, over 15 million, and we've heard a bit about what that world is like. So where we are today is not a good picture. Further, you have the facts, for instance, that the top 10 causes of death, Alzheimer's is the only one without a way to cure, prevent, or even slow it. And you put these facts together and you start to understand why Alzheimer's is one of the most feared diseases in America today. When we poll this, especially for those over at midlife and beyond, it's the most feared because people know what this experience is like and what it does to families and what it's doing to our country. So that's one side of the picture. On the other hand, we have some reasons for optimism. We've heard that. We have, in the case of Washington, D.C., Congress really starting to take this disease on. We see a lot being poured into research. This hasn't yet changed the lives of those who are facing this disease, and we still have a ways to go. But we're living between these worlds where we see the tough realities today of what we face, and we're also seeing that we are on the path to changing that. We just have to keep going quickly, even more quickly, as we think about not just the research, getting these treatments, and then what we do with them and how we provide better care.
And maybe I'd open it up to one of our doctors. I mean, we don't have a cure yet or a treatment yet. I mean, do you have a sense of what that would look like if we got one? I mean, would it be kind of just one pill that everybody can take, or would it be a very kind of different thing depending on, the specifics of the patient, I guess?
So, again, also echo Rob's thanks for really convening today's conversation, and really delighted to be here. So my role is as a geriatrician and internist, and I volunteer my time with the Dementia Care Clinic with the Veterans Clinic in Baltimore. So I will respond to your question about what does it need to look like? And I think what it needs to look like is something that works. So one key part of this is knowing that a treatment would work. We should think about this broadly in that it would be optimal if we had multiple treatments, and if we knew which treatments work best in what populations, or even what populations a given treatment doesn't work in, right? So that really it provides the opportunity for patients, people, caregivers, and their clinicians together to make choices to find the best fit of a intervention, a treatment for each and every person who develops dementia. So I think, that's what it could look like. And our system is preparing to be able to catch whatever innovation actually is introduced into the system. But I think we have to think broadly. At the same time, we have to think in a very focused way so that we know what outcomes are meaningful to people and so that research and clinical practice and policy can converge on those outcomes.
Mm-hmm. And if anyone else wants to jump in, I mean, also an issue, I guess, is how does diagnosis fit into that? I mean, presumably you need to know somebody has Alzheimer's, early enough, or to know that you can treat them. So, I mean, how can that be a challenge even once we have some treatment?
Yeah, I think there's a lot of sweeping this diagnosis under the rug, and it starts with the patient, because the patient often will say that there really is just normal aging, or it's just, all my friends have memory problems. So, and then the family takes their cues from the patient, and the doctors take their cues from the patient and the family. And so it's really underdiagnosed, and it's not really diagnosed properly. A lot of patients are given a diagnosis of dementia and then not lead on to say dementia due to what? Dementia due to Alzheimer's, the Lewy body dementia, frontotemporal dementia. There are lots of causes of dementia, and it is underdiagnosed. It is also undertreated. There are 4 drugs that are already FDA approved. We certainly need better and more effective drugs, and we look forward to the day when we will have better and more effective drugs. But there are drugs available now for treatment that have some modest efficacy. So I would encourage patients and families to seek evaluation, to get an accurate diagnosis, to seek treatments, and then also to learn about possible research opportunities that are out there to discover these new drugs. I estimate as a guess that perhaps less than 1% of Alzheimer's patients participate in any research whatsoever. We really need to increase this number.
And Dr. Wood, I mean, how does the primary care you're kind of on the front llines there, so I mean, how does that kind of fit into this picture?
You took the words right out of my mouth as the front line.
Yeah.
So as a family physician, a primary care physician, it's going to be, and is already, but continue to emerge, very important for us to be ready to know about emerging treatments, but also understand the patient in their whole context, and their family and their community, what resources are available to them, how do we integrate with public health. There's a lot of opportunities, but we're often the very first physician that they see, and so we want to be ready, and we want to screen properly and be able to treat, diagnose, refer, and help their family as well and their caregivers along with the patient as a whole.
And I mean, just in terms of the situation now, are there things we should be doing better in terms of how we're treating people, whether that's, as we've kind of said, diagnosing, realizing more people have the disease, or getting people onto drugs that maybe they're not on now? I mean, what's kind of the things, even before we get a better treatment that we should be doing?
Yeah, so I'll take a crack at a response.
Yes.
So I think what you're alluding to is probably one of our biggest opportunities, which is connecting care, right, from detection that there's a problem to a diagnosis to developing a plan of care that is really true to the goals of care of each and every person and relevant to their caregivers as well. Mm-hmm. So I think that is a very different construct from how the system has behaved, thus far in a fee-for-service context. So there again, it gets to, what do optimal outcomes look like from a system level that is still meaningful to each and every person who either is diagnosed with the disease, may get the disease, or their family members. So I think that connectivity, there's tremendous opportunity to establish. And the approach to focus on outcomes and value, I think, is a tremendous opportunity as well.
And that we measure that value in an appropriate and effective way that actually helps improve patient outcomes.
Absolutely.
I think when we get more effective treatments, there'll be more incentive to make an accurate diagnosis and to look for Alzheimer's and to begin to treat it. There's a lot of negativity. There's a lot of opinion that it's not worth getting a diagnosis. There are no effective treatments out there. Why bother? But that's really not the case. There's a lot we can do now, and there's a lot more we hope to be able to do in the future.
Mm-hmm. And Robert, I mean, since we're in D.C., we heard a little from the senators earlier, but I mean, what are you looking for in terms of a congressional or administration response? I mean, I know there's a bill being marked up on Thursday, even so that's something.
That's right. It's already been an exciting year. With 2 appropriations bills were resolved in this calendar year. Each contained a historic increase for Alzheimer's research. That's absolutely essential and exciting. We've already talked about that we need to do more of that. At the same time, there's other fronts that have been underway. Some of it is the work agencies are doing. For instance, CMS has a very important study right now called the IDEAS study that gets at diagnosis and what we can do with that information effectively. This legislation that you referred to, called the Bold Infrastructure for Alzheimer's Act, will be marked up on Thursday. And it's a great opportunity to end this session strong with a bill that will focus on creating a public health infrastructure for Alzheimer's to complement the great work that's being done in communities already. And that would be part of the answer for when we have treatments, for instance, that we are ready to make that diagnosis and get people through these transitions that are, as you said, Dr. Ling, so critical for better care.
Mm-hmm. And Dr. Wood, maybe you, I mean, we were talking a little about this before, but I mean, this training issue, I mean, is there, do you think doctors, I guess, know enough? You know, if you're just a normal doctor out there, do you know enough about, you know, oh, here's what I should be looking for this person might have Alzheimer's? Are there things we need to do better around training or education and that kind of thing?
There's definitely an opportunity to step it up and also understand that this really is a public health issue. It's a public health crisis emerging with all of our numbers that we're hearing about today and are concerned about. I also think there's an opportunity for research, not only with the wonderful biotech and pharma companies, but also at the level of primary care research. What can we do with that patient that comes in our office with their family member? Those interventions are less researched right now and less funded. So I think it's an and we have a lot of opportunities there. So definitely we need to provide education for physicians, and that would be in medical school, in residency, and also after they're out of their residencies. The physicians that are already actively practicing also need support, because perhaps our young physicians have learned more as they've come through, but our established physicians can also use more information as these technologies and medications continue to present themselves in a great opportunity.
And I would add that there are not enough neurologists, psychiatrists, geriatricians out there to diagnose and treat the millions of people with Alzheimer's and the millions more that are coming. So we're going to have to rely a lot more on the primary care, the front line, the family practice physicians, and give them more education and training so that they're more comfortable with the diagnosis and treatment.
And have good systems in place that we can have bidirectional or unidirectional communication that helps us whatever is appropriate for that patient and their family, so that there's more connection. I think you mentioned it. Often our system, the way it's set up now, is fairly disintegrated, not with bad intent necessarily, but it turns out that way. So I think it's very important for primary care and our specialty colleagues to be working together on this on behalf of the patients.
And part of the work of the National Alzheimer's Plan has been to, develop and push out the educational curriculum to train healthcare professionals, not just physicians, but healthcare professionals about the disease. What are the management strategies, what to look for, how to actually think about providing the care that is needed. And that is something that our federal partners at HRSA actually led the way on, as well as our colleagues at ACL. So it's been not just a federal effort, though, really requires partnerships with professional societies from specialty all the way down into primary care. So I think this is a all systems approach, all professionals approach that has to really go forward.
And I mean, then through even your careers, I mean, the time you've been practicing, have you noticed an improvement in either the kind of the awareness or less stigma or kind of getting better at going through these steps?
There's been a big breakthrough in diagnosis, and that is amyloid PET imaging. And we can detect amyloid in the brain 10 to 15 to 20 years before somebody gets Alzheimer's disease. This new technology has permitted prevention trials, so we're now looking at prevention trials. In the future, we hope to go from treatment to more prevention. There are estimated 5 million plus individuals with Alzheimer's in the United States now, and there are estimated about 50 million people in the United States that have a positive amyloid PET scan, meaning that they may develop Alzheimer's in 5, 10, 15, 20 years. So we hope to move towards more prevention efforts. So I think this biomarker technology has really been a big breakthrough during my career, and we hope to turn that, of course, into treatment breakthroughs in the coming years.
And that'll be really exciting as far as primary care goes. So when we know that there are ways that we can look to prevention, which is a main facet of primary care, then we can continue to look for ways to prevent, along with good preventive care for the whole person.
And I think there's tremendous opportunity to think about this, again, from a systems approach. Primary care is really a critical part of the solution. Neurology care is really, and dementia-specific care is really a critical part of the solution. But the people that we serve, our beneficiaries, actually also receive care in hospitals, in post-acute care settings, in nursing homes. So how do we actually provide the skill sets and the integration across these care settings? I think that is, again, a need and an opportunity and a challenge at the same time.
I think that's a great point. Many of the stories I hear for the last 10 years from caregivers and those with the disease directly are much the same as they were. And that shouldn't surprise any of us. That there's the same fundamental challenges. Going into a hospital, we were just talking about this, and the questions that the person with dementia is asked directly without the care provider necessarily being informed that they already have dementia. Those kinds of fundamentals, being discharged with complex discharge papers and no support to interpret what they're being told to do, how to fill a prescription, for instance, that's still going on today. And one of the things that we need to do in terms of integration are things like the Independence at Home pilot that Senator Markey described. Those kinds of looks at how we can help with the transitions, make this more seamless, provide the support that people need is still sorely needed. The other thing, Peter, that I'd mention, and along the theme that you asked about, is the integration between state and federal policy. Senator Tillis talked about this a bit, and that is also fundamental. As people transition between different settings, you're going back and forth, especially in the context of Medicaid, between things that are under with federal jurisdiction, between state jurisdiction, and back and forth. And that, for too long, has hobbled what we can do, but I'm optimistic we're tackling those issues as well.
And Dr. Lee, maybe just talk a little about what kind of CMS or the administration is doing on these fronts. I mean, are there particular initiatives or programs that you have going?
So a couple of I think, major steps forward, and CMS remains the largest payer for healthcare services globally. So importantly, we have introduced opportunities for early detection into programs that CMS has the authority to implement, including the annual wellness visit, right? And that was the first step towards really sending a signal that assessing cognition is really an important part of a wellness visit. But we also needed additional evidence to say that, a given test or screening tool should be used. And so I think we created a new opportunity through a new billing code, a cognitive impairment evaluation billing code that not only addresses, use of a standardized tool, but also includes the caregiver assessment as part of it. And in addition, created a billing code that permitted clinicians to manage people with multiple chronic conditions, because one of the challenges with dementia is that it is very rare that a patient has just dementia. Right. They'll have diabetes, heart failure, a variety of other conditions that also really require cognition to effectively manage. So there's an additional billing code there. Now, all in all, though, focusing on delivering high-value care, which we're talking about new care and payment models that Rob was actually alluding to. And so part of the work that the Innovation Center, which under specific authority, which included testing new care and payment models to improve quality and reduce costs, preferably both, created new opportunities. There were several Healthcare Innovation Awards that were focusing on people with dementia and providing care differently. I think that some of the findings were promising and yet didn't quite meet criteria for improving quality and reducing costs, but still, I think, really promising notions like that Rob was referring to, that a person with dementia is not alone in their care, that you acknowledge the dyad, the caregiver as well. So I think there are some really promising findings there. We have a Comprehensive Primary Care Plus track that pays for a baseline care, baseline services a little bit differently. So it's not just fee for service. It's creating the opportunities to attend to the complexity that people with dementia and their caregivers and families actually challenge the healthcare system with. So that's some of the important work that CMS has been part of.
I think we're going to open it up to audience questions now, so if anyone has a question, please raise your hand. Right. No? Yeah, right here.
Thanks. I'm Martha Taggart with Bright Focus Foundation. My question is, through all the panels, no one's really addressed behavioral or lifestyle interventions, prevention through those. How important, if any one of you would like to address how important that is, and how we can build that into, brain health, into the Alzheimer's prevention scenario.
I can tackle that one. I often get the question of how can I avoid your clinic or not have to come to your clinic, and I give them my usual advice, which is maintain ideal body weight throughout your whole life so that you don't get diabetes and other medical illnesses. Physical exercise, social activity, mental activity, obviously no smoking, Mediterranean diet, no head injuries, which means helmets and things like that when you're younger, and fall prevention when you're older. And all of these things probably could delay Alzheimer's 5 to 10 years, but I also tell my audience that if you do all of these things, you're probably going to live another 5 to 10 years. So it may just be a question of delaying your Alzheimer's disease as opposed to not getting it. But all these recommendations are also good for general health and heart health anyway. So these are ways to try to postpone or avoid the memory disorders clinic.
And just a very quick other aspect to your question is the behavioral aspects that accompany these dementias, which are such a source of the struggle of these diseases. And on that front, I couldn't agree more with the importance of that question. And as you alluded to, I think person-centered care can sound like a cliche, but we're learning how important that is in caregiver guidelines, for instance, and care provider guidelines, to really recognize the person and how to deal with them directly in a way that addresses the sources of what we call disturbances or behaviors that really are very understandable when you start to think from their perspective of what they're going through in those times, and often have great difficulty, especially if we're not listening, communicating to us. So that's a very important aspect of better care.
One last question, I think, over there.
Again, thank you for this wonderful panel. My name is Lauren Lukey, and I'm delighted to hear all of this wonderful information. Rob Egge had talked about person-centered care and infrastructure. And from any of the panelists, could you give me your top 3 items for infrastructure that you would like to see right now as a public health issue? Thank you.
Who wants to tackle?
Would you like to?
I would like to see more support for the front line, the family practice physicians, the primary care providers in having more education so that they're more interested in making a diagnosis and treatment. We need more research. It's great that we've had a big boost in the NIH research budget and other research budgets, so it's nice that we are making progress with more research funding. This problem is as big as cancer and should get equal funding to cancer, but it's always historically been much lower. And then the final is that we need more support for patients and families not just in managing their Alzheimer's disease, but also in perhaps helping them facilitate joining clinical studies and clinical research so that we can make more progress. We need more than 1% of Alzheimer's patients joining research if we're going to make any significant progress with this disease.
I'll throw in from an Alzheimer's Association perspective, we're thinking in terms of health systems, right? We're thinking, as you heard, public health systems, especially at the state level. So if I were to compile my list right now at the moment, I'd be thinking a lot about how can we equip community and state public health departments to also engage in this challenge we face as a nation. And then private health systems, the importance, because they often will trace through the transitions of care along with assisted living facilities and others that are all part of this story and supporting people at home. So it's easy to come up with a list that exceeds 3, I think.
Yeah.
And I think to your point with the public health infrastructure, that integration of public health and primary care coming together can be very strong. It's already starting to happen somewhat, but I think this is an area where we can really demonstrate value and need.
All right, well, I think that's all our time, so thanks to all our panelists.